One of the most constant pursuits we have had in the myeloma field for decades is how to give patients the same great result while omitting the toxicity and the risk associated with autologous transplant. All the trials that we have done that take outcomers have consistently showed that every time you omit transplant from the initial therapy, you compromise progression-free survival, compromise disease control. That question has not been yet answered yet again on the area of quadruplet induction therapy. That are trials that are pursuing that, and I would emphasize the IFM MIDAS trial that take patients who are MRD negative after 6 cycles of azacitidine randomized to a transplant-containing versus a transplant-deferring strategy. And we're going to do that on the MASTER-2 trial as well, in the same setting of patients who are MRD negative. However, the reluctance in part of abandoned transplant comes from the verification that is the proven most effective therapy in increasing the proportion of patients who are MRD negative. And on the MASTER-1 trial, where we had serial assess of MMRD, we could really zoom in the impact of transplant on disease burden. And it's really remarkable that after very intense quadruplet induction with Dara-KRD, you still have an average of 1.1 log reduction in disease burden. And that reduction is even more prominent among the patients with higher risk disease, which I think traces a very nice correlate with the observation that has been made, for example, in the EMN02 trial or in the determination trial, that the higher risk patients are the ones who derive the most benefit from transplant.